part-time in the NHS, and part-time with Quesmed as an editor. I won't go through Quesmed, as you all know, it's a very comprehensive kind of revision tool. We have the app, we have the website, you can work on flashcards, SBA questions, we've got a Quesmed book, and obviously we have these wonderful OSCE platform launching shortly. So yeah, take advantage of all that. So just to crack on with our plan, so we are doing single best answers in general practice today. And this lecture is primarily question-based. So we're going to cover single best answers, or SBAs. And these are topics that are likely to come up in your final exams. So we're trying to pick topics that not only will likely to come up in your finals, but they're also things that are likely to come up in your medical career and in any placements in general practice. So the format's going to be, I'm going to ask you a question. I'm going to give you 60 seconds to read the question, and a poll will pop up and you should be able to submit an answer. And then we'll talk through the question, we'll talk through the correct answer, and we'll talk through the other answers and why they are not correct. So let's just dive straight in with the first question. So you will have 60 seconds to read this question and to pop an answer in the poll.
That's about a minute. Shall I end the poll?
Yeah, end the poll, please, after 60 seconds. Wonderful. Thank you so much for answering there. So most people are getting the correct answer, but a bit of variability. So let's talk about hypertension. So hypertension is one of those most common things that you'll deal with as a general practitioner. So let's just go back to basics. What is the definition of hypertension? Now, the definition of hypertension is a clinic blood pressure of over 140 over 90, or an average ambulatory blood pressure of over 135 over 85. So for most people, if their clinic reading is high, that you'll recommend them to get an ambulatory blood pressure monitor. And that's a profile taken over usually a week, just because white coat hypertension is a thing. And we classify hypertension into stages. So stage 1 being clinic blood pressure over 140 over 90, stage 2 being 160 over 100, and stage 3, that's the scary one, that is severe hypertension, and that's when the systolic is over 180 or the diastolic is over 120. So in terms of treatment, so pharmacological treatment should be considered in those with stage 1 hypertension who have organ damage, cardiovascular disease, renal disease, diabetes, or if they have a 10-year cardiovascular risk of greater than 20%. And we also treat anyone with stage 2 or stage 3 hypertension. So this 10-year cardiovascular risk, what exactly is that measuring? So that is measuring your risk of a cardiovascular event, so a heart attack, a myocardial infarction, or a stroke. And it's only valid for patients who have not already had a cardiovascular event. So obviously people that have already had a heart attack, they're already at greater risk of having another one. So this is of people that have not had any cardiovascular events. And it takes into account demographics, so age, sex, ethnicity, UK postcode. It also takes into account your clinical history, your smoking status, if you've got diabetes, your family history, and it also takes into account things that you measure in the clinic, so BP, BMI, cholesterol, but you can plug in as many details as you know and it will help you to calculate a risk. So in terms of results, over 10%, we class that as moderate risk, and that should merit a full assessment. So lifestyle, management of any comorbidities, and thinking about treating if there is hypertension there. And a risk of over 20%, that is considered high risk. So we've also now got the Q-risk 3, which includes even more things that are associated with a higher risk of cardiovascular disease. So this adds in things like migraines, mental illness, and steroid treatment. And up here in Scotland, we use the ASSIGN score, and that's tailored to our Scottish population. And again, that takes into account similar things, so age, sex, your postcode, diabetes, things like that. And again, it assigns a risk. So this is a nice flowchart which guides us in the diagnosis and management of hypertension. So for our guy in the question, his blood pressure was 155/98. So he's falling into this middle category here, and he was rightly given ambulatory blood pressure monitoring. And we should also assess for target organ damage. We might want to take some blood, check his kidneys, things like that. And we want to plug his details into a risk calculator. We did offer him ambulatory blood pressure monitoring, and his ambulatory blood pressure was still high. It was 150/96. So he is falling into the stage 2 hypertension. So the treatment here is both lifestyle advice and pharmacological management. So looking at the rest of the flowchart here, this helps to guide us in treatment. So this guy here, we know he's got hypertension. We've checked and he doesn't have type 2 diabetes. He's under the age of 55, and we're told he's Caucasian, so he's falling into the white category. So we are heading towards step 1, and we're heading towards treatment with an ACE inhibitor or an angiotensin receptor blocker, an ACE-I or an ARB. Now, generally we go for ACE inhibitors as first-line therapy, as these have got the most robust evidence in terms of lowering blood pressure. Quite often, ACE inhibitors are notorious for causing a dry cough, and some people really struggle with that. So actually, we do switch people to an ARB quite often. And let's also just remind ourselves of what is the aim of this game, what is the target. Over here on the right-hand side, it just goes over the target. So we're aiming to get this guy's blood pressure below 140/90. So checking back with the question here, the correct answer is C, to commence an angiotensin converting enzyme inhibitor, an ACE inhibitor. If his readings were high but below the threshold, we might think about A, we might think about lifestyle factors, we might think about returning in 6 months, but he definitely does have stage 2 hypertension, so he needs treatment. And the reason we wouldn't go straight for a calcium channel blocker, beta blocker, or angiotensin receptor antagonist is they are simply not first line. So first line's an ACE inhibitor. If they're struggling with that, with the dry cough, we might think about an ARB. And calcium channel blockers and beta blockers, they are further down the line in terms of management. So first line management, stage 2 hypertension is an angiotensin converting enzyme inhibitor, an ACE inhibitor. Most of you guys got that right answer there, so well done. So let's move on to the next question. And again, I'll give you 60 seconds to read the question and pop a wee answer in the poll. Perfect. Thank you all for answering there. So what do we have here? We have a young woman here. She's just come back her holidays and she's got an itchy, painful ear. We've done otoscopy, we've looked inside the ear and we can see it's wet, it's swollen and it's inflamed. And we're trying to see the eardrum, but we can only see part of that just due to the swelling of the ear. And the eardrum itself appears a little red, but there's no evidence of swelling or discharge. So let's think about ear stuff, another mainstay of general practice. Let's start with otitis externa. So this is inflammation of the ear canal, and that's the skin part you can see just inside the ear with the naked eye. And that skin canal, that continues right up until the tympanic membrane, the eardrum. Typical symptoms of otitis externa are acute onset ear pain, often with an itching sensation. And people often describe it as a fullness. Sometimes people can have hearing difficulty due to the swelling. And it typically occurs after contact with water. So it's sometimes nicknamed swimmer's ear. And it's also quite common in people that aggressively clean their ear canal. So those people that are guilty of using cotton buds can quite often suffer from otitis externa. And people that live in areas of high humidity and people that have other skin conditions. So if people already have dermatitis, if they already have eczema, they're at greater risk of having otitis externa, because at the end of the day, this is a skin condition. On examination, you'll find that it hurts the patient if you tug on their ear or if you push on their tragus, and the skin of the ear canal itself will appear inflamed with variable degrees of swelling and discharge. Now, it can be quite difficult to delineate between otitis externa and otitis media. So in otitis externa, remember there's an inflammation of the skin of the ear canal, the outer ear, and that's in front of the tympanic membrane. Whereas otitis media, that is a middle ear infection. That is an infection of an area behind the eardrum. Comparing symptoms, so otitis externa is typically rapid onset, it's typically painful, and it often has this fullness, this reduced hearing. And there may or may not be discharge, there may or may not be hearing impairment. In otitis media, there's also pain, but it's often preceded by an upper respiratory tract infection, and there might often be other symptoms of a sort of viral illness. So people might have a fever, might have a headache, might even have systemic upset. So quite often children that have otitis media, they're quite often vomiting, they're irritable, they're just not quite right. And otitis media happens quite commonly in young children, and it might manifest simply as irritability or a toddler crying all the time, pulling at the ear. Risk factors, so risk factors like we've already been over for otitis externa is swimming, cleaning your ear, high humidity and skin conditions. Risk factors for otitis media is having an upper respiratory tract infection, and it's more common in younger children. On examination, so how do you examine to try and figure out which is which? So I normally start by pulling on the ear. In otitis externa, this usually leads to pain because you're flexing that ear canal, you're flexing that sore skin. And then we look, so we can look with the naked eye first. You can see a little bit of the ear canal just with the naked eye. And in otitis externa, you can see that that is red and swollen. You might see discharge, you might see a crustiness of the external ear. And then we go on to otoscopy, so looking in with the otoscope, and we're looking for the tympanic membrane. So in otitis externa, the tympanic membrane might be red, but it's usually otherwise normal. Whereas in otitis media, remember this is a middle ear infection, the tympanic membrane quite often looks abnormal. It might be bulging, you might be able to see an air fluid level, you might lose that light reflex that you normally get, and in severe cases, you can actually see a hole in the tympanic membrane, a perforation. In terms of causes, remember otitis externa, that is a skin infection, and that is typically caused by bacteria in the skin of the ear canal. Whereas otitis media, that is often a viral infection. In terms of management of otitis externa, we normally treat that with topical antimicrobial ear drops, with or without a steroid if there is bad swelling of the eardrum. So we typically use ciprofloxacin dexamethasone, and that is just ear drops that are placed into the ear multiple times a day. In some cases, we use ofloxacin, and a mainstay is just simple analgesia, so paracetamol, ibuprofen. For those people that this doesn't clear up, we can think about systemic antibiotic therapy, and we'd normally prescribe something like Cipro or amoxicillin. So checking back with our question here, this girl with a sore ear, the correct answer there is our antimicrobial and steroid ear drops. So that is answer E. So most of you got the correct answer, but a few picking other options there. So let's check the other options. A is oral amoxicillin. What's that used for? Now, remember, otitis media is normally caused by a viral infection. However, quite often, if that doesn't settle, we do treat that as we presume it's a superimposed bacterial infection. So some GPs will provide a delayed script. So typically for little children that have got a sore ear, the GP might provide mum with a script for amoxicillin and tell the mum if this isn't getting better in 3 or 4 days to get that script and to treat with antibiotic therapy. But that's for otitis media, oral amoxicillin. Olive oil drops, that is useful for cases of people that have excess wax, people that have blocked ears due to wax, but that's not going to help an otitis externa. That's not going to help clear that inflammation, clear that infection. Oral phenoxymethylpenicillin, that is Pen-V, and that is the treatment for tonsillitis, where you think it's due to a strep throat infection. And beta-histine dihydrochloride, what is that? And remember, that is a histamine analogue, and that's used to treat sort of vertigo conditions, tinnitus, things like Meniere's disease. So that wouldn't help in this case. So the correct answer there is cyproldexamethasone eardrops. So moving on to the next question, again, you will have 60 seconds to read the question and pop an answer in the poll. Wonderful, thank you for answering. Again, most of you getting the correct option there, but thank you for participating. So here we've got another young girl, and she's troubled with dry skin. She's had this for years, and she describes the affected areas as the flexor surfaces, so the inside of the elbows, behind the knees, and between the fingers. It sounds pretty bad. There's evidence of excoriation, there's bleeding areas, and there's even some scarring. So let's think about skin stuff, and we'll start with atopic dermatitis or eczema. This is one of the most common skin conditions you'll see as a GP. And this typically presents with dry, itchy skin with varying degrees of redness, erythema, scaling, vesicles, scarring, or even lichenification. So it tends to affect flexor surfaces. So we're thinking inside the elbows, behind the knees, and in skin creases. So places like inside the finger webs and in between the buttocks. And it commonly affects children, and it commonly affects the face in children. Risk factors for atopic dermatitis, well, other atopic conditions, so things like asthma, things like allergic rhinitis, food allergies. It is more common in people under the age of 5, and it is more common in people with a family history of similar things. And the diagnosis is primarily clinical, and treatment, the mainstay of treatment is emollients, so moisturisers, keeping that skin as moist and supple as possible. And we treat with topical steroids for any flares. And here's just some typical images of atopic dermatitis. The first one there, that's an elbow, and you can see there that you can see it's affecting those little creases in the elbow. You can see there's scabbing, there's obviously been some bleeding, and that looks very, very itchy. There we can see in the middle picture, it's affecting the bits between the skin. And again, that's creating sort of hardened bits of skin, scarring. And here in the rightmost picture, we can see it's affecting the toes. And again, that person's been itching. You can see bits of excoriation and breaks in the skin. So let's think about seborrheic dermatitis. So this is another red, itchy, inflamed skin condition. However, it's typically more greasy, and it's typically has these characteristic greasy, scaly patches. It affects the scalp, where it's commonly known as dandruff. It affects the folds in the face, so the nasolabial folds are just beside the edge of your nose. It can affect the ears, it can affect the chest. In terms of risk factors, it is more common in children under the age of 3. So that's normally known as cradle cap, sort of a scaly, greasy scalp. It's more common in people that are stressed, so stress can precipitate this. And it's interestingly, it is more common in people with things like Parkinson's and HIV. Diagnosis again is primarily clinical. Often emollients are not required because the skin condition is quite greasy. And flares again are treated with topical steroids where required. In terms of treatment, we can also use antifungals. So there's some evidence that seborrheic dermatitis is caused by an overgrowth of a particular fungus. So topical antifungal therapy may also play a role. And let's just look at some pictures of some seborrheic dermatitis. So in the first picture there, you can see it's kind of affecting that bit behind the ear, and you can see it's affecting the scalp. You can see bits of dandruff there. In the middle picture there, you can see those kind of red outlined patches. Those are quite well demarcated patches on the scalp of seborrheic dermatitis. Now, you don't normally see those as well demarcated in people with lots of hair. This guy's obviously shaved his head, so it's quite easy to see the areas. And you can see in that rightmost picture there, you can appreciate that that looks quite greasy. That doesn't look dry like eczema, it looks quite greasy. Moving on to contact dermatitis, and as the name suggests, this occurs when the skin is in contact with some sort of irritant, and it therefore manifests as well localized areas of localized redness, burning, stinging, and sometimes even swelling and blistering. And it typically occurs under jewellery, so nickel is a common thing to have contact dermatitis to. Clothing, any sort of new clothing, new washing powders, things like that can trigger contact dermatitis. And risk factors are simply exposure to the irritant, so exposure to nickel if you're allergic to it, exposure to certain washing powders, and also it's more common in people that have atopic dermatitis. Diagnosis again is clinical, but if the trigger is not clear, we might use patch testing. So we might use common allergens as a patch test to see if we can trigger that contact dermatitis and figure out what's causing it. And the treatment makes sense, remove the trigger. So if you're allergic to nickel, avoid nickel jewellery. If it's something to do with your washing powder, avoid using that. And again, we can use topical steroids for any flares. So some pictures of contact dermatitis here on the left there, that's obviously caused by a ring. And on the right there, I think that's an arm that's been caused by a watch and the person's had contact dermatitis to it. Moving on to psoriasis. So psoriasis is often confused for other skin conditions. It also presents with a red scaly rash. It's also itchy. Now it characteristically has a silvery white scale and it tends to affect the extensor surfaces. So we're thinking about the kind of backs of the elbows, the front of the knees, and it can also be accompanied by other psoriatic features. So you quite often get nail changes in psoriasis, and you can also get psoriatic arthritis. And it is more common in those with a family history, and there's a very strong genetic component to psoriasis. Flares, again, are quite often triggered by stress. Diagnosis, you guessed it, it's clinical, and treatment is with emollients and steroids, kind of the same as eczema. However, psoriasis often responds well to vitamin D analogues and phototherapy. And in bad cases, we can also think about using biologics for psoriasis. And here's some pictures of psoriasis. So here we can really appreciate that white scale, and that's characteristic of psoriasis. We can see it in the armpit there, we can see it on the skin on the front of the knee, and we can see that appears really quite different, really quite characteristic. So it's quite different from eczema. So checking back with our question here. So this lady had dry, inflamed, scaling skin, evidence of excoriation, and going by the presentation, it's the inside of her elbows, it's behind her knees, it's between her fingers. So the most likely diagnosis here is atopic dermatitis or eczema. Checking with the other answers there, B, seborrheic dermatitis. Remember, that's the one that's more greasy and it often affects more the face and the scalp. Contact dermatitis, we'd probably see well demarcated areas. So she might be able to pinpoint areas where there's been a contact with an allergen. And looking at psoriasis, so psoriasis, there's no mention there of the silver scaly bits. It's not a typical distribution, so psoriasis tended to affect the flexor surfaces, and eczema tended to affect the extensor surfaces, the flexor surfaces. While there's an indication that this person might be suffering from low self-esteem, I don't think anything in the question really suggests it's a self-harm. I think those bleeding areas are from her scratching at her skin rather than self-harm. The correct answer there is A, atopic dermatitis. Moving on to question 4, again, you'll have 60 seconds to read the question and pop a wee answer in for me. Lovely, thank you for answering here. So here we have a 44-year-old obese man with a sore knee. And the key points on the history is that the pain came on quite suddenly, the knee is swollen and the knee is warm. His range of motion is limited, but he is able to weight bear. And curiously, he mentions that he's had some similar episodes affecting that same knee. And he also mentioned something about a sore big toe a year ago. And again, those resolved spontaneously, he didn't need any treatment for that. So let's have a chat about sore joints. So let's start with gout. So gout is caused by uric acid crystals amalgamating in the joint. It presents with a rapid onset joint pain and swelling. There's sometimes an effusion, sometimes a visible redness to the joint. The joint might be stiff and the joint might feel warm. And it typically affects the big toe, but actually I find it more affecting the big joint, so the knee, and it can also affect the foot, ankle, fingers, wrist, elbow. It can really affect anywhere in the body. The typical patient is male, they're obese, they're around 40 to 50 years of age, they've got a diet that's high in meat, they've got a diet that's high in seafood, or they drink a lot of alcohol, and diagnosis is normally clinical. So we normally would diagnose and treat this clinically. However, if we did do a joint aspiration, we would characteristically see negatively birefringent needle-shaped crystals. We quite often check uric acid levels, and these are usually checked after the acute flare has passed, because uric acid levels will be reassuringly low during an acute flare. So quite often we'll treat this as gout and we'll bring the patient back in sort of 6-8 weeks and we'll check their uric acid levels then. And management, the acute management is things like painkillers, so NSAIDs, colchicine. In severe cases, we can use steroids. And for those patients that keep getting gout, we can think about using a preventative therapy. So we use allopurinol, and that's a xanthine oxidase inhibitor. So what that does is that stops your body from creating uric acid. Talking about pseudogout. So pseudogout presents very similarly to gout. However, it is much less common. And it's caused by calcium pyrophosphate deposits in the joints. It presents in a slightly older age group, and it can be triggered by injury. And it often presents in older patients as a worsening of osteoarthritis. It's got a few associations with things like hyperparathyroidism and hemochromatosis. Again, diagnosis is clinical, and it is difficult to delineate gout from pseudogout. If you do a joint aspiration, you will see a different picture. You will see positively birefringent rhomboid-shaped crystals. And management is similar to gout. Management is with non-steroidal anti-inflammatory drugs, and in severe cases, a steroid injection. So if you were worried about which one it was, gout or pseudogout, they are treated very similarly. There's a slightly different kind of clinical presentation. And if you really wanted to know, you can perform a joint aspiration and you can look at those crystals, send them off to be looked at under the microscope. So let's think about osteoarthritis. This is another one of the most common things you will see in general practice. And this is a degenerative joint disorder. This is wear and tear on the joints. And it's characterized by gradual onset joint pain, stiffness. And it typically affects the joints that we use the most. So the knee, the hip, the hands, and the spine. And it is more common as we age. Pretty much everyone as they enter older age will have some degree of osteoarthritis, of wear and tear. Diagnosis is clinical after ruling out scary things of joint dysfunctions, but we can also do x-rays which can show signs of osteoarthritis. It's slightly more common in females, and it is much more common in those that are obese, because if you think about it, this is wear and tear on the joints. If you're carrying more weight, your joints will wear earlier on in age. So obese people tend to get osteoarthritis at a much earlier age. And management is with analgesia. We might need to use steroid joint injections. And in cases where it's very severe, very life-changing, we can think about joint replacements, particularly hips and knees. Moving on to septic arthritis. So that is an emergency situation of an infected joint. It typically presents with acute onset joint pain and a hot, swollen joint. Typically, there's a reduced range of motion. We would expect to see a fever, and typically people can't weight bear if they've got a septic joint. And it tends to affect just one joint. Knees are quite common. And risk factors, they're things that think about introducing infections, so injecting drug users, having a prosthetic joint, increasing age, and anything that's going to immunosuppress you and place you at risk of infection. Diagnosis is normally clinical. Some units tend to use scoring criteria. So the Kosher criteria is quite a common one. It uses things such as non-weight bearing, temperature, white cell count, things like that. And if you score 0, it essentially means that you are unlikely to have a septic arthritis. Ideally, we want a joint aspiration. That not only confirms the diagnosis if we find bugs in the joint, but we can also culture that aspirate, and that will help us guide our antibiotic therapy. And moving on to therapy, therapy is with intravenous antibiotics. Oral antibiotics don't tend to get to the joints very well, so we normally start with intravenous antibiotics. Most people require analgesia, and we might perform aspiration and wash out, and that is as a therapeutic procedure to suck out all that bad stuff, wash it out, and hopefully get rid of the physical infection. Psoriatic arthritis, now we touched on this when we talked about psoriasis. So that is an inflammatory joint disease, and that typically presents with a polyarthritis, so many joints being affected. And it typically affects the hands, the feet, and the spine. And the strongest risk factor here is having psoriasis of the skin. So people with psoriatic arthritis almost always have some sort of skin psoriasis as well. And it's very common in people with a family history as a strong genetic component, as we've already mentioned. Diagnosis, again, that is clinical, and it's treated with non-steroidal anti-inflammatory drugs. And we would consider these patients for disease-modifying anti-rheumatic drugs, so DMARDs. That's things like methotrexate and biologics. So checking back with our answer here, the correct answer is gout, caused by those urate crystals amalgamating in the joint space. So this guy, he hits a few of the risk factors, doesn't he? He's male, he's overweight, he's the right kind of age, he's presenting pretty typically with a acute onset, one joint being sore. And curiously, he's got a classic history. So he's had similar episodes in the same knee. And that's typical of gout. Gout comes and goes, it has flares. PseudoGout, yep, that presents pretty much the same as gout, but it's much less common. So in this question, it's asking what is the most likely diagnosis. So PseudoGout, they both affect the same joint, typically a knee. PseudoGout, like we mentioned, does tend to affect a slightly older population, sort of over 60s, whereas gout tends to be the kind of 40s to 50s. And gout tends to be much more sore than PseudoGout. So PseudoGout can almost go unnoticed. People sometimes don't present with that, but gout can be excruciatingly painful. Septic arthritis, yep, that also presents with an acute onset sore knee. However, this guy doesn't really have any risk factors for having a septic arthritis. It doesn't mention injecting drugs or prosthetic joints or anything like that. Doesn't mention that he's got a fever, doesn't mention that he's systemically unwell, and he is able to weight bear. So that's all kind of pointing away from it being a septic arthritis. And osteoarthritis, now he is obese, that is a risk factor for osteoarthritis, but osteoarthritis, that tends to present quite gradually. So a gradual worsening, chronic onset. It doesn't generally have significant swelling or kind of acute onset pain, but you might well have some underlying osteoarthritis. Psoriatic arthritis, remember we said that rarely presents in patients without skin manifestations, and it typically doesn't have such an acute onset joint condition. It presents more insidiously, more gradually, so it's unlikely in this case. So most likely answer here is gout. So well done, guys. So moving on to the next question, again, I will give you 60 seconds. Wonderful, thank you for answering. Again, most of you guys getting the correct answer with a few spread over the other answers here. So what have we got here? We've got a worried lady with a mole. So let's revise our criteria for assessing moles. So moles are assessed using the ABCDE criteria. So A is for asymmetry. Now, usually moles are pretty symmetrical, whereas worrying things like melanomas are more irregular, more asymmetrical. So you can see the picture on the left there, that is a mole, and that looks pretty symmetrical. It looks pretty regular. We can see the edges of it. Whereas the one on the right there, we can see that's quite irregular. There's lots of different things going on there. It's not perfectly round. It's certainly not symmetrical. B is for borders. And a typical mole has smooth and well-defined borders. So if we look at that picture on the left there, we can see the border is very well defined there. We can draw a line around that quite easily. Whereas on the right here, we have, this is a melanoma. So typically that's got quite irregular borders. So we struggle to kind of draw around the edges of that well. It's just not very well defined. So B is for borders. C is for colour. So moles tend to be a pretty uniform colour. It's all one colour. They could be very light, they can be very dark. So the picture on the left there, that is just a normal mole. That is quite dark in colour, but we can see it is all the same type of dark. Whereas the one on the right there, that is more of a melanoma. And we can see there's tons of different colours in there. There's light brown, there's dark brown, there's paler colours, there's pinky colours, lots of different colours in that. So C is for colour. D is for diameter. So moles tend to be small. They tend to be less than 6 millimeters. And we can see there on the left there, that's a mole there. That's tiny. It's dark. So that's looking quite reassuring. And we can see there, the one on the right there, that's a bit more worrying. You can see that's really quite large. It's spreading outwards. And again, that's not got good borders. That's not got a uniform colour. So that's a more worrying image. So D is for diameter. And E is for evolution. So most moles don't change much over time. They might grow a little bit, but they don't change dramatically. They don't change in colour. They don't change their borders. Whereas a melanoma, that would spread. It can become different colours. It can start bleeding. We can see irregularities appearing. And this image here just shows you the kind of normal progression of a melanoma. So we can see here this starts off as quite an insidious little brown thing. It gets darker, and then we can see lots of colours appearing in it on the right side. We can see the borders starting to become a bit irregular, and the whole thing just looks quite different to the first picture. And those pictures are only taken kind of year 1, year 2, and year 3. So you can see that's evolution over time, which is a worrying feature. So the correct answer here is E. The mole has got darker over summer. Looking at the other answers there, A, it's okay for a mole to be oval shaped. It's more about having symmetry and having well-defined borders. Looking at B, people quite often have multiple moles. Some skin types are more prone to moles. So you'll see some folk have more moles than others. And C, the mole is soft and wobbly. Moles are typically soft and wobbly. This is not a worrying factor. That's quite a reassuring factor. And having hairs erupting from the mole, again, that is a reassuring factor because that's indicating that's normal skin, and skin should have hairs coming out of it. Quite often the hairs coming out of a mole are darker, coarser than normal hairs. And again, that's a reassuring feature. So the correct answer here is E. The mole has got darker over summer, and that's hitting those criteria of C for colour and E for evolution. So that's a worrying mole. So moving on to the next question, I get another 60 seconds. Lovely, thank you for answering. So a mixed bag of answers there. So what do we have here? Here we have a gentleman that has painless rectal bleeding. He's not got any red flag features, so what do we do? And what are those red flag features? So it's easy to jump to, oh my gosh, rectal bleeding, 2-week wait referral, but let's be logical and consider what are the red flags. So obvious things like unintentional weight loss, anemia, if you felt a mass, a rectal mass or an abdominal mass, if there's a change in bowel habit, and if there's no obvious cause for the bleeding. But here we've got a man that's got limited fresh red bleeding on wiping. He says that he's prone to constipation and there is examination findings consistent with hemorrhoids. If we didn't find hemorrhoids on examination, so we found those protrusions, tender swellings palpable, there were no mass, just tender swellings. If we didn't find hemorrhoids, then there's no obvious cause for the bleeding and we would think about referral. But obviously in general practice, we cannot refer everybody that has rectal bleeding. We've got to examine them. We've got to rule out the common things. So let's talk about hemorrhoids. So hemorrhoids are very, very common and are sometimes referred to as piles. And these typically present with painless rectal bleeding. Often the bleeding happens after having a poo, particularly if they're prone to constipation, particularly if they find themselves straining on the toilet. And they might often be accompanied by a general discomfort down there, an itching and a feeling of something coming down. And people might actually describe to you things coming out of their bum that they then push back in. And hemorrhoids are graded 1 to 4, depending on how far they protrude, if they prolapse and if they can be reduced. So this man sounds like he's got grade 1 hemorrhoids. You can feel them, they're there, but they're not visible outside and they don't prolapse. And these can be managed quite conservatively with lifestyle changes and with topical steroids. So let's go on and just talk about management in a bit more detail. So grade 1 hemorrhoids can be treated with topical steroids. And we want to carefully think about lifestyle management. So this guy says he's prone to constipation. That sounds like it's a long-standing thing and it's not a change in bowel habit for him. But we want to think about introducing more fibre into his diet. We might even need to treat him with some stool softeners just so he can pass stools without straining. Grade 2, so they're the ones that are coming out, but they're popping back in on their own, and they can be removed quite quickly and easily as a kind of outpatient appointment with rubber band ligation, sclerotherapy, or photocoagulation. Grade 3, they're the ones that don't go back in on their own, and they are more suited to rubber band ligation. And grade 4s, they're the ones that come out and they don't go back in. Now, they need surgical management, they need physically chopped out. So going back to our question here, it sounds like this man would be suitable for treatment with a topical steroid cream. For example, we use hydrocortisone, and that's applied twice daily for 5 to 7 days. Steroids also come as a kind of suppository, and that might be easier for him to use. So that's a suppository, a wee tablet that's inserted into the rectum twice daily, and that can be used for 7 to 14 days. And steroids can then be used intermittently whenever symptoms flare. If these hemorrhoids weren't resolving, we would think about kind of other therapies such as the rubber band ligation, the sclerotherapy. But first line management, we try a bit of steroids. We try and improve his lifestyle. We try and improve his bowel habit. So the correct answer is topical steroid cream. So rubber band ligation, that's for kind of higher grade hemorrhoids, ones that are poking out, ones that are not going back in. Sclerotherapy, again, that's for hemorrhoids that are not going back, sort of poking right out. And referring for a lower GI endoscopy, that I would reserve for people that have other worrying symptoms of a bowel cancer. So if you had a mass, if you had a change in bowel habit, if you have weight loss, any other risk factors for a bowel cancer, yeah, of course, we'd be referring him from endoscopy. But this man doesn't have any particular risk factors for a bowel cancer. So we're going to treat him with a topical corticosteroid treatment and see how he goes. So moving on to the next question, again, 60 seconds. So there's quite a lot to read on this slide. Lovely, thank you for answering. So what have we got here? We've got a young woman, 37 years old. She's had some bloods done because she is feeling tired. And what are the key things we're homing in on here? So she's anemic, her hemoglobin is low, her red cell count is low, her hematocrit is low, and she has a reduced mean cell volume, but her mean cell hemoglobin concentration remains normal. So we can classify anemia based on mean cell volume. So microcytic is a mean cell volume of less than 80, macrocytic is greater than 100, and normal is kind of 80 to 100. So in this case, her MCV was 70, so she is falling into the category of a microcytic anemia. But why? So let's remind ourselves of the causes of different types of anemia. So she has a microcytic anemia. So causes of a microcytic anemia are things like iron deficiency anemia, but can also be caused by things like thalassemia, anemia of chronic disease, and sideroblastic anemia. If she had a normal cytic anemia, we might think about things like anemia of chronic disease. So when I say anemia of chronic disease, I mean things like kidney disease, rheumatoid arthritis, lupus, any other sort of autoimmune conditions, infection, malignancy. A macrocytic anemia, that's typically caused by B12 or folate deficiency, but we also see this in people with alcohol problems and liver disease. So this flowchart is from the BMJ, and that tells us what to do. So this patient's falling into the category of a microcytic anemia. It's got a mean cell volume of less than 80. So it tells us exactly what to do next. We do serum iron studies, and also known as hematinics. And what does that include? Hematinics typically tells you the serum iron, the total iron binding capacity, and the ferritin. So in terms of iron deficiency anemia, we would tend to find a low serum iron and an elevated total iron binding capacity. And that is the most common cause of a microcytic anemia. So iron deficiency anemia, it's not really a diagnosis in itself. It's more this has been what's caused. So what is the underlying thing that's causing an iron deficiency anemia? So we need to still think about why. So things like increased menstrual bleeding. She was 37, so we'd want to ask about her periods. Are they particularly heavy? Are they particularly long? We can also have reduced intake. So does she have a poor diet? Does she have some sort of malabsorption? Is she bleeding in other ways? Does she have GI bleeding? Does she have hemorrhoids? Does she have a peptic ulcer we don't know about? Does she have a diverticulosis? Is there malignancy? And an iron deficiency anemia can also occur in the context of increased demands. So is she pregnant? Is she lactating and using up more iron? So iron deficiency anemia, that's easily treated with oral iron replacement therapy. We quite often see that, but it's worth remembering that it takes at least 3 to 4 weeks to see an improvement in hemoglobin and 2 to 4 months for it to fully normalise. So it is worthwhile treating her and bringing her back in a few weeks and bringing her back again in a few months. When oral iron isn't tolerated, so sometimes people don't like it, upsets their tummy too much, we can think about IV iron, so intravenous iron, and that's normally in the form of ferric carboxymaltose, which is known as Ferinject up here in Scotland. And in cases where anemia is profound or they're very symptomatic or their red blood cells count is very low, we can obviously think about blood transfusion. So the correct answer there, what was the next thing to do? And the next thing to do, as we saw in that BMJ flowchart, was to order hematinics, because this slide in itself doesn't actually tell you the full picture of what's going on. And we normally would want to order hematinics before we go ahead and treat with iron, because we don't know if it's an iron deficiency anemia. So checking with the other answers, while iron deficiency anemia is the most common cause of a microcytic anemia, it is important to rule out other conditions. So we want to think about thalassemias. Does she have any family history? Sideroblastic anemia, any family history of that? And quite often, if the hemoglobin is very low, the lab will automatically look at the red blood cells to check they are normal. And you can request a blood film. So that's where the lab physically looks at the shape and the size of the blood cells to see if they are normal. B, order urgent upper and lower gastrointestinal endoscopy. That would be indicated if in the history there was some indication of upper GI or lower GI bleeding. So does she have coffee ground vomits, or does she have black stools? Is there other red flags? Is she losing weight? Anything like that. Ordering a repeat full blood count, I'm not sure that's going to be particularly helpful. Red blood cell count doesn't tend to fluctuate much over the course of a few days. And it's clear the patient is anemic. I think ordering another full blood count isn't going to reveal a different result, as it's still going to show us the same result. And refer to haematology. So this patient's got a microcytic anemia. We haven't fully investigated that. So I don't think haematology would accept a referral for someone that is anemic that you haven't done any further investigations with. So in general practice, we can do iron studies and we can treat for iron deficiency anemia. Of course, if there was any other red flags, if we were worried about a hematological malignancy, we would think about referring to haematology. But here, I don't think haematology would be best pleased with a referral for someone that is anemic and we've not even tried to investigate or treat that. So that's not a right answer there. So thank you for answering. On to the next question. Again, there is 60 seconds. Perfect. Thank you so much for answering there. So let's dissect the situation again. What do we have? We have got a guy with a lump in his neck. It's been there for a while. It's not painful. However, he does have a few red flags, doesn't he? He's feeling tired. He's got dysphagia. He's admitting to a bit of weight loss. Let's just have a quick recap of neck anatomy. Now, broadly speaking, we've got the anterior triangle to the front and we've got the posterior triangle to the back, and they're separated by that big sternocleidomastoid muscle, that one that goes all the way from the ear all the way down to the clavicle. Looking at it again, surface anatomy wise, we can see there, we can see the anterior and posterior triangles, and half the battle of general practice is referrals and being able to describe things that you don't have a huge amount of knowledge of, because you're going to be doing a referral for this guy, aren't you? So it's important that you're able to describe where this lump is in terms of anatomical position. So that's a wee recap of the kind of surface anatomy, and on the left there we can see those anterior and posterior triangles. So in this case, it sounds as though that lump was in the anterior triangle, just below the mandible. So it looks as though that is going to be in sort of the submandibular, the submental space. So we've already got a bit of an idea as to where that lump is. And here's a wee image of the various salivary glands. So they're the exact thing that is hiding in that wee space there. And it's sounding like what we're feeling. It might be the submandibular gland, or it might be the sublingual gland. It's not quite clear what we're feeling, but it sounds as though it is going to be one of those glands that you're feeling that's enlarged. So let's just check back with the question here. The location of the lump, that's in line with a submandibular salivary gland. And this combination of the history and the examination findings, I mean, that really to me sounds like he needs an urgent referral for investigation of a neck cancer. He's got a few red flags and it sounds as though he's got a swollen salivary gland. So I think he is heading towards a referral to head and neck. Looking at the other answers there, B, a submandibular salivary gland stone. Yep, that might well present as a swollen salivary gland. It's usually more painful, and it's particularly painful on eating, and it doesn't tend to cause things like weight loss. So I'm not convinced it's a salivary gland stone. The location of the lump, again, said it's really important. So at the parotid gland, that is the one that's just below the ear. So that's extending into the posterior triangle. That's not really the right place for that. And while lymphoma is certainly a differential, I think it usually presents with multiple swollen lymph nodes. So in this case, he's got one thing that's swollen, and I think that is his submandibular salivary gland. Why is it not the thyroid gland? Well, the thyroid gland is in the midline of the neck. It is one of the ones that tends to move with swallowing, whereas we're told it doesn't move with swallowing, so it's not likely to be a thyroid gland tumour. So the correct answer there, the most likely diagnosis is a submandibular salivary gland tumour, and we would be referring him urgently for a potential head and neck cancer. Moving on to the next question. We're almost there, guys. 60 seconds again. Perfect. Thank you so much for answering again. So to me, this woman sounds like she's having migraines, isn't she? So migraine is typically headache, presence of aura, so visual or sensory disturbance, and diagnosis is based on having at least 5 headaches lasting 4 to 72 hours. And quite often people have nausea, quite often people have their eyesight going a bit weird, photophobia. And quite often these are unrelieved by simple analgesia. So that kind of fits the history there. She's having headaches that can last days. She's having sickness. She's not able to be helped by simple analgesia. So that definitely sounds like migraines to me. So just going over the kind of diagnosis of migraine. So migraine, the definition is a headache with an aura, visual or sensory disturbance, or if they have at least 5 headaches lasting sort of 4 hours to 3 days with associated nausea, vomiting, photophobia, phonophobia, and any 2 of the following. So is the headache unilateral? In this case, yes. Is it a pulsating character? Is it moderate or severe intensity? So that's things that are going to stop you from doing your daily activities. And is it worsened by daily activities, or do you have to go and lie down and go to your bed? So definitely she's hitting the criteria for migraine, isn't she? And in terms of management of migraine, this is split into acute management and prophylaxis. So in terms of acute management, this is a bit of trial and error in GP. Normally we try things like simple analgesia, so paracetamol, ibuprofen, aspirin can sometimes help. Caffeine is helpful to some people, but not others. However, many people find the 5-HT agonist, the triptans, the most useful thing in treating an acute treatment of a migraine. So most often we go with triptans, but some people, their migraines do respond to paracetamol, aspirin, NSAIDs, things like that. And in terms of prophylaxis, if someone's having multiple migraines that are really affecting their life, we think about having them on some sort of prophylaxis. And the first thing is normally a beta blocker, so something like propranolol. But we can also think about things like anticonvulsants, so carbamazepine, topiramate. Worth noting that anticonvulsants are contraindicated in women of childbearing age that are not using contraception. So in this scenario, she was a young woman, so we probably want to steer away from those unless she was on an effective contraception. And other prophylactic treatments include calcium channel blockers and tricyclic antidepressants, so things like amitriptyline. So checking back with the question there, the key part is prophylaxis. So remember and read the question. So the question's answering what is first line for prophylaxis of headache. So you might well jump to diclofenac being the right answer because that's an acute treatment, but make sure you read every word in the question. So sumatriptan and diclofenac, they're out because they are management of acute management of headaches, not for prophylaxis. So we're left with verapamil, carbamazepine, and propranolol. Now, the first line here is propranolol, which is a beta blocker. And like we mentioned, we'd probably steer well away from carbamazepine in a 33-year-old woman unless we know that she's got effective contraception on board. Well done, guys. We have managed to get to the end. I've got a couple of questions I'd just like to answer, and they're both related to the kind of last question there. So it was this guy here that had a lump in his neck. And people are querying what is wrong with this guy. So is it an esophageal cancer until proven otherwise? Yeah, absolutely. He's got dysphagia. So yes, we're definitely thinking esophageal cancer. The thing that's making me more towards a submandibular salivary gland is firstly the fact that that is an answer and esophageal cancer is not an answer. And also the fact that we can very clearly feel one swollen gland. So typically esophageal cancer, you can't find much on examination, but we can find this lump. So yeah, while we're thinking esophageal cancer, it's not there in the answers, and we can feel the swollen gland, so we're more thinking towards salivary gland. And the other thing I was going to answer was why it's not lymphoma. So it could be lymphoma, I completely agree with you. There would be the same systemic symptoms. He might have weight loss, he might have feeling more tired than usual, but he has this very palpable one lump, which is exactly in the spot where the submandibular salivary gland is. It's increasing in size, and he's struggling to swallow. So all of these are pointing more towards a salivary gland than a lymphoma, but absolutely that would be on my differential. But I think in this case, the most likely diagnosis is a submandibular salivary gland tumour, because we can feel that. Perfect. In terms of slides, the slides themselves are not uploaded, but the entire lecture is uploaded onto YouTube. So feel free to peruse the lecture, pause it, write down things at your leisure, essentially. But thank you so much for listening.